All right, thank you. Next, we are going to be doing our panel discussion on on-call conundrums. I'm going to have my friends and colleagues come up to the stage, and we'll get organized. That's you, Dr. Shepard. You're up. All right, and then Jenny. All right. And I think I'm going to let you guys sit up here, and then I'll sit. I'm going to sit down here with our questions. All right. I'm sure no one in this room ever has had trouble with on-call issues, so. All right. I'm going to move my table over here, and we'll get started. I guess I'll control it. All right. I'm going to have you guys go ahead and just introduce yourself to the crowd.
Now we are on. My name is Jenny Albertson. I'm the Director of Quality and Regulatory Affairs at the Colorado Healthcare Association, and I've been a practicing nursing home administrator since 2005.
My name's Dave Shepard. I am an internal medicine physician, medical director, and a board member of PALTmed, Colorado.
I'm Leah Ginsberg, nurse practitioner, and also a board member of PALTmed, Colorado.
And I'm Jenny Foster. I am the Director of Nursing at a nursing facility in Fort Collins. I think it's on.
All right, good. We'll get going. All right, so these are some of the key things that we thought we'd go over, because there's always interesting things that come up at 2 in the morning. So we are going to go over abuse reporting, change in status, when your call isn't answered, and then also like when and how and who you should be notifying. Sorry, we already did that. All right, abuse reporting after hours. Who and what is involved? So here's our clinical scenario. We have an 85-year-old female. She was seen by your partner earlier in the day for complaint of arm pain. There's no known fall or injury. And they ordered an x-ray earlier in the day, but unfortunately returns that evening with a new humerus fracture. So, too many buttons. Sorry, I got a little excited. So we're gonna just kind of talk about, because we don't have a known source of injury, what would you recommend doing on call if this type of scenario were to arise? Who would like to start? Jenny looks excited.
I'm going to go first because it's like, alert, alert, call your administrator, please. We have to start abuse reporting immediately and an investigation. We don't have a source for the injury, and it's an actual significant injury, right? This is not just a bruise of unknown origin or a skin tear. This is a time-limited intervention. And of course, you're going to come up with your own clinical interventions, but you need to get our back channels going for abuse reporting and investigation.
Yeah, and as far as the physician taking the call, I think most of us would probably send this patient to the hospital for further evaluation, orthopedic consultation.
I think it's also helpful to know that this is a possible abuse reporting situation as a clinician to say, have you told your director of nursing? It's not something that I would necessarily have thought of. So I think it's important to ask that question potentially.
I agree with all of these guys. As a director of nursing, I would expect to be notified, no matter if it's 2 in the morning or not, just so that we can start the investigation due to the time reporting criteria that we have to follow with the regulations. So.
Just so the group knows, what are those time requirements that you guys are talking about? What time frame should we be doing reporting in?
For a significant injury of this sort, we would have up to 2 hours to get that initial report in to the state.
And that does not mean that you know what caused it by then, just so you all know. The definition for reporting is simply a suspicion or an allegation. And so that clock starts immediately upon recognition of the injury, or in terms of the 2 hours. And then we have 5 days to complete our investigation and go through the full process of interviewing staff members and finding out when that injury was first noted, et cetera.
Yeah, I kind of just had a question. How many physicians in here have taken a call like this and thought to themselves, we need to report this as abuse? and initiated that. Yeah, I don't often think of it either, but we probably should. So that's something else for us to keep in mind.
And I think that is one of those like key questions when you're on call is asking, was there a source for injury?
And just another note on that, it doesn't necessarily have to be something intentional to be considered abusive. Think about the fact that you can injure one of our fragile elders in the process of a transfer with no ill intent and no deliberate use. But I'm not quite sure what that sound was. It was definitely not me. But you may have a transfer competency issue with a staff member. You may have equipment failures. There's all kinds of things that could contribute to an injury of this nature that you may find that there actually is not true abuse. However, in some of those situations, it may still classify as a reportable under neglect as well, because if there's misuse of equipment or an inappropriate or lack of competent care given in terms of a transfer, you may have it under the neglect provision. Still reportable.
And does it change at all when there isn't a significant injury as far as like the time requirement for reporting?
Go ahead.
Yes, it does. If it's a situation where there's not a significant injury, we're not contacting providers for further guidance. We have upwards of 24 hours to get that initial report in.
So definitely important on our nighttime, like weekend calls especially, I think, when not everybody is in the building, so.
And you may not be aware that your administrator is on call 24/7. They may not act like it. They should be acting like it.
So is your director of nursing.
And is this something that you guys typically notify medical directors of? Do you guys, as a DON, do you usually call your medical director, or do you notify them later on in the process?
I think it's a good idea to notify our medical director of everything that's happening within the facility to keep them apprised so that they know if there's any trends or things that maybe we're not seeing in the moment. They are a very valuable part of the team, even though we don't see them every day.
Any additional thoughts, friends? All right. Oh, do you want to do questions in between? We can. Does anyone have any questions or comments regarding these kind of calls? These are tricky. Ooh, I got to take her. Okay. Liz does have a loud voice. We'll let her talk.
So as an on-call provider, do we have any legal documentation we have to do other than, notified of injury, unknown origin, and recommend the staff call the DON or the administrator? Does the on-call person have anything we need to do?
I do not believe so. So when we do our initial and final reports, we do have to notify, or there's a spot on there that marks that a physician was notified, medical director notified. So typically the investigation piece of that and the follow-up to the reportable, the portal to put those into CDPHE is on the administrator or director of nursing, however the facility has that set up.
Now, that said, there is an elder abuse reporting law in the state of Colorado, and we are all mandatory reporters. And so if you didn't think that it was properly followed up on, like you didn't get a hold of an administrator in DON, for example, you would also be required to report it as a fallback position, and you would need to document that you had done so. But the full investigation piece should be documented on the facilities side, and we do include a police report with every suspected abuse because it meets a felony statute in the state of Colorado, even if it's a missing item that they thought was stolen, et cetera.
Yeah, and I'll just add, as a physician in PPA, if I get this at 3 in the morning, I'm not waking up and going down and document it, but I am the next day. I'm going to document I got called, do my best to estimate the time, what happened, mechanism of injury, and what was done. And that, I think, that's just good medical practice, in my opinion, good documentation. And from a legal perspective, I would think that would certainly be a way to cover both your liability and potentially the facility's liability.
Great question. Is there any other questions out there? All right. We will move on to our next topic then. the change in status. All right, so you have a 72-year-old male with history of Parkinson's. He has neurogenic bladder and a chronic suprapubic catheter who develops a new onset of abdominal pain. He's lethargic. His blood pressure is low, according to the nurse who calls you. Gosh, I'm like button happy, guys. Sorry about that. So this is not an uncommon scenario. So what are some of the approaches that you guys might use or recommend in this scenario?
I want to know what his goal of care is, number one. I think we sometimes forget to ask about that. So, it sounds like a person who probably wants more things done, but never assume.
Yeah, I would agree with that. And whenever somebody uses the word lethargy, I think we're all kind of trained to get real nervous when that word comes up, right? Low blood pressure, we're thinking sepsis here just clinically, right? So knowing the goals of care are even more important because your next step for this person, the hypotensive, tachycardic, lethargic, altered mental status, we're thinking sepsis, and that's something we probably cannot treat in the facility. So.
What do you guys feel like the role of the POA is in these change in statuses, given that sometimes most forms and whatnot can be fluid, that people change their mind? Do you typically have nursing staff reach out to the power of attorney to make sure that they want care in place and not transfer out?
Yes. So after hours, the nurse would need to be doing a full assessment, getting all that information to provide accurately to the provider when they call them. And even if they are 93-year-old DNR, most form comfort care, a POA still can change their mind and say, no, I want to send them to the hospital and treat. So it's super important to have that information for your provider when you call and say, yes, they're a DNR and they are comfort-focused treatment, but the daughter really wants them to go, the resident really wants to go because they still have the choice too. And then that helps the provider give us better guidance on what to do because sepsis is not something to take lightly and it is something we need to treat quickly. So having all that information up front is going to be best, calling the provider.
Yeah, and do keep in mind also that a POA is not necessarily in effect. So if the resident and the POA happen to disagree or the resident does not want the POA involved in this decision, they get first right. If they are deemed incompetent and the POA is put into effect as the decision maker, that's when you call the POA before or over and above the resident's decision.
That's a great call out because it can be pretty nuanced in some scenarios. So what about with nursing staff when they call you? What are the things that you're going to be routinely asking for as far as like a nursing assessment?
Well, it would be nice to get a full set of vitals. Hopefully they have that. Not always true, right? And I would like to know if they've listened to their abdomen. When was the last time they maybe had a bowel movement? And are they eating and drinking okay? Those would be kind of some of my initial questions.
Yeah, and the next day we're definitely going to be pulling all of the I's and O's if there happen to be I&O tracking. I hope so in this scenario. What has the hydration level been in terms of intakes and outputs? This actually came up because it was an immediate jeopardy citation recently, this case, partly referencing. And the resident ended up in the ICU. So that's part of why I wanted to make sure we included this situation.
Yeah, I would just like to have a second vote for vital signs, please. Vital signs are vital, right? So please, physicians, and we're not perfect either, but if you call a physician with a case like this, please have vital signs and please have done an assessment and present the case. That's a skill that seems to be, God, I sound like an old man. It seems to be lost now sometimes in some of our younger nurses and physicians too, for that matter. So present the case, give the data that we need to make good medical decisions.
And I also think it's a great opportunity to provide education. So if it is that new nurse that's on the floor, kind of like Leslie was talking about today, leading with kindness, asking questions, and like trying to build that relationship by phone so that and it's hard to do at 3 in the morning, right? That's real hard to do sometimes, but, you know, because you want them to call you in the future. And I think that's the key, is like, you don't want to shut somebody down because they may not call you the next time. It's really important.
And if they're not kind to you, you need to tell the facility management.
That's true. That is very
Yes.
true.
So as our esteemed keynote speaker told us, right? Act with humility, be clear, be transparent, and also it's a potential opportunity for education too, right? If this is someone who doesn't give you a very good presentation, walk them through it, help them, and learn from it, coach, and then I'll just admit, and probably every physician here can admit, that at some point they've gotten called at 2 in the morning and they have not been nice. And so, you know, you wake up the next day and you're like, I probably could have handled that better. Find that person, apologize. I've been amazed at how far that will go. That's some of the best nursing relationships I have, is the people that I started out on. You know, we started on the wrong foot because of something I did or they did, and we worked through it and we apologized, and our communication infinitely better from that point forward. So,
Yeah, that's great. Are there any, like, you know, especially too from like a DON perspective as well, like with agency staff, because that does always kind of present at these change in statuses with, you know, some unique scenarios after hours too.
What's agency staff?
Like,
I'm totally kidding.
Jenny doesn't have agency staff.
Agency staff, it can get a little tricky in facilities too. I think it's setting up a good process and communicating the needs. If you are going to call the on-call person at night, like, what does that look like for that nurse? You should have, you know, solid processes in place so that they know what to do when they're calling and the information that they need. It does get a little challenging if you do have agency nurses in the facility, because they come in and they're just trying to make it through with their shift. They don't necessarily really know the people in depth at the level that a nurse that is on staff consistently would know. So again, that's not having full agency in your building for one. Have some consistent nurses and strong leadership on all shifts. So. And then the DON support, like if the DON has agency in the building and they know that that might be a little soft on that shift, then being available to take calls and help problem solve through whatever happens in the moment too.
Yeah, and a lot has to do with just the process of getting an agency person to start their shift properly. You know, do they feel like they got greeted when they came in, or did they just figure out, oh, where's the time clock, and start their shift with zero orientation to where they find the call numbers for the docs or a sense of welcome? They will treat people more nicely when they are treated nicely.
How do you balance these scenarios with readmission rates when you're under the pressure to try to keep readmission rates low? Are there things that you guys are doing in your facility to help address that?
I think one of the most important things is preventing things to get this far. So more assessment, more awareness, being proactive and not reactive. Checking the trends of vital signs with your residents in-house and having your managers follow. If they're acting off, let's look at that a little bit quicker and see what's going on and try to get things in place before it gets to the point where they're septic and we're sending them out. So.
Yeah, and some buildings are cooperating with their hospitals to flag records as prone to sepsis from history of. If you have a hospital flagging their records that way, adopt it into your EMR practice as well so that it carries through and your staff know what that means and what they should be watching for.
That's great. Do we have any questions from the audience? There is. Oh my goodness, you guys are gonna make me run across the room. I'm coming.
Dr. Shepard, I know you said that vital signs are real important, and I work for CDPHE, and one of the things we see is that the blood pressure machines are like the home type from like Walmart. Does that make a difference when you're making a medical decision?
Yeah, of course I would like a validated blood pressure machine, right? And there's a list of those that you can get from the ACC website. Wrist cuffs are always kind of iffy. Some would argue whether or not manual versus machines are going to be more accurate. Usually nurses call me with a manual, and I'm fine with that. But yeah, the home cuffs I worry about. But at this point, when we're at this point, whatever data I have, whatever I can get is what I'm going to have to use, right? Well, hopefully our nursing homes are using validated blood pressure cuffs and machines, and they're taking a blood pressure accurately and correctly. Occasionally, in a case like this, if it's during the day when there is someone there that I know, and I get in trouble for this sometimes because people might get offended that I'm asking for someone else to evaluate the patient, but I'll ask the DON or someone to go take a look. And sometimes the story does change. So 2 sets of eyes are always a decent thing to consider as well, yeah.
Great, thank you.
And it's perfectly valid for a medical director to say to an administrator, we need to invest in new vitals equipment, or what is holding us back from a cooperative agreement with Rosie? You know, if you feel that there is a standard of care that would better represent what you do, it's valid to bring that to your quality improvement committee or to the administrator as a potential capital expenditure.
Oh, I left you.
I want to give a plug to PALTmed, former AMDA publication called Know It All Before You Call. I think it's still available. And it goes through a variety of clinical scenarios of what then is recommended for the facility provider, LPN or RN, to do history-wise, assessment-wise, how to organize their thinking, and then how to organize the phone call to the on-call mid-level or physician. And then it has a companion thing for those people receiving the phone call of what to go through, what requires immediate action, what can be done in a day or two versus what's more of a chronic problem. So it's a good series of publications that are helpful for the staff.
Thank you. It is. It kind of creates a better dialogue. And I always tell my staff, I'm like, just keep asking questions, because sometimes if you just keep asking questions, you'll get the key information that you know. All right, here's Dr.
First of all, Know It All Before You Call is still available, but I just wanted to say I work with exceptional DONs. I'm so lucky to work with the DONs that I work with. And one of them has instituted that if there is an agency nurse, and it is even 2 o'clock in the morning, that agency nurse reviews the case with the DON before they call the provider, so that it's a really cohesive process. And I so appreciate that at 2 o'clock in the morning.
Yeah, I would agree with that, and I'm going to piggyback on it, because the facilities that I see who are able to lower their hospitalization rates are the ones that have something like that in place, to where the DON or ADON or somebody who's a pretty good clinician is in between the decision to go to the hospital or not go to the hospital.
Yeah, I think that's important, as we've had such an influx of nursing that's come in through COVID after the COVID years, and we've had a lot of people leave. I think having that mentorship is really helpful as well. Is there any other questions from the crowd? All right. Very good. Do you guys have anything else on that one? Thank you. All right. This never happens, ever, when your call isn't answered, and this goes on both sides. So, well, gosh, me and my buttons today. So maybe we can talk about it from both perspectives. Not only as a practitioner, you get the call, you're already on the line with another facility, so another one's calling you, they leave a message, and you call back and you don't get the answer. And then also when, from the nursing side, when you call and you haven't gotten a response in a timely fashion.
We just had that happen.
Oh, good. That would be my fault.
It was a very minor thing, though. It's going to happen, right? We're taking care of people. Doctors are stressed for time. They get lots of calls. I think a goal is always to try to minimize how many times we have to call an on-call for something, and really be for those situations that are unexpected that are coming up. And then also, again, DON, ADONs being available for on-call to talk it through. So whoever's in charge, they say, I can't get a hold of the on-call. What do you want me to do? Well, what is that situation? Is it like a life or death emergent, do we need to send them and then just call after? Or do we need to say, okay, let's pause, increase monitoring, keep calling, and those types of things. And also having those conversations if they continue to be an issue, speaking with medical director about, okay, we're having trouble with on-call, how would you like us to handle this? And having that collaborative relationship with providers.
I think the more specific the phone number that's left, the better. So if it's just the main number and nobody's going to answer it, it is frustrating as the clinician, right? Like, you're never going to get through. So even a cell phone or something like that, if the staff is willing to share that, I think that's always better.
Yeah, I would agree with that. So from the medical director's side, that's why we're available 24/7, right? If there's an emergency, no matter what time it is, and you can't get a hold of the physician, call the medical director, right? Use your best judgment. If this is something urgent, call them now. If it's something that can wait, maybe you hold off a little bit. From the other side, being a physician who got the call and is trying to call back, I don't know what the correct answer is, but I know what my answer is. So I have my DON's phone number, I have my ADON's phone number, and I have the administrator's phone number. And if I can't get a hold of somebody, I usually give them 3 tries, 30 minutes maybe, and then I'm calling either the DON or the ADON, and if I got nothing there, I'm calling the administrator. And usually I can get through to one of those, because at 2 in the morning, you have to assume this is urgent. Why else would they be calling you like this at 2 in the morning? So during the day, I think you might have a little more flexibility or leeway. There's other people you can get a hold of, but I agree. I've got hundreds of names and numbers in my phone, and I can look them up by facility, and I will just start calling people if it's more than 30 or 40 minutes.
And just so you know, you're not just being a pain in the neck when you call the administrator. The admin and the DON probably have covered staffing a few times, and that means they have everybody's cell phones in their work phone, which means they also know who's on duty tonight, because before they left, they checked the staffing roster, and they know exactly who is on that unit, and they're going to call their personal cell phone, which of course they're going to pick up because it might be their kid, and they will then go give you information and put the phone in the hand of the nurse that should have been picking up the call when you called. So it is imperative that you bring it to the administrator's attention. Also, it might be an operational issue that's ongoing, or even if it's just the once, if it's an operational issue, it needs to be handled by the administrator. They might have a cordless phone that they're expecting people to carry that nobody ever carries, or nobody charges at the end of their shift. It could be that they have a pager system that's failing. There could be any number of things going wrong that are at the root of that problem, and they need to be given the advantage to solve that problem.
I think cell phones are great, because sometimes too, like, the physical footprint of a facility is such that if you call the main line, each wing is not going to know who called. So I find that to be really helpful. So.
I'm going to add one more thing that frequently happens. I'll call back and I get sent to voicemail at the facility. I have no idea what this means. I think maybe when I started doing this, I left a message, and then I decided this is futile. This is not a good idea. There shouldn't even be a voicemail on this. So that's another thing to keep in mind. Be very wary of facility voicemails. I don't know what abyss they go into, but I'm not sure how often they get checked.
And as I said, the aforesaid operational issue.
Does anyone?
Good judgment.
Good judgment. Yes. Does anyone from the group today have any other thoughts or ideas that you've utilized in these scenarios? Right. That's a good one. All right, we'll move on to our last one. So this is kind of broad, but when, what, and how to notify. So kind of as a piggyback off of what we talked about previously as far as like abuse and those kind of things, what are things that practitioners need to know, like that we should definitely be saying, you need to call your DON on this? Or is there any other scenarios that you can think of?
One scenario I can think of is we have a resident who had a fall. It was unobserved, and they're on a blood thinner. So calling the provider and notifying them of that situation. Some providers like to send out right away for evaluation, but then is that best practice? Because again, sending somebody to the ER could be detrimental to them, and it could be 2 a.m. and we're sending them out, and then they get all these tests and come back and it just wears them out, and then they end up having a negative CT scan and vital signs are fine. Could we have monitored neuros and talked to the provider and whatnot within the facility and had criteria when to send out? So that one seems to be kind of confusing for nurses quite a bit. So.
Again, know your patient's goals of care, in my opinion. That really helps.
Yeah, fall of injury is definitely a good one to call about. If we get called with an elopement as a provider, what are some things that we should be doing? And who should be aware of the elopement? Because this happens more than you probably want it to,
Like not at all, please?
Like never, but you always get that skilled patient that somehow just managed to find their way out the door. And
Yeah,
so,
if you notice someone following you out the door, that's considered an elopement. There's the administrator or DON, whoever is the actual highest ranked individual in terms of staff hierarchy in the building, has to immediately start procedures if there is an elopement. So if you are made aware of it, you need to know who knows, because the concentric circles of searching, the looking in every room. I found an elopement in a closet once that was not even supposed to be unlocked. For hours we looked everywhere for this person. I mean, you have to really do a lot to resolve an elopement, and so the sooner you can start that process, the better. So definitely make sure you know who has been told and that there is a process started. If you happen to be on grounds, join in the fun and start searching the neighborhood with your local CNA. Elopement is something that we have to report also to the state. If it goes, 4 hours, 8 hours, if you cannot find the person. Oftentimes there is a history, and so if you are aware of a history with elopement or routine self-transfer to the hospital, for example, that may be something you want to mention to the staff as they are searching for the person, because that may trigger something in their thought process about something the patient said earlier in the day, they were agitated, etc., and you can kind of get to the root of where you think they may have gone.
Then you also just want to make sure that the facility policies are followed with elopement and notifications throughout what your policy is suggesting. Because if you are a building that doesn't have a locked memory care and you don't have a wander guard system and this person just got out of your building, what are you going to do for the next 15 minutes? You need to have somebody with them one-on-one or call the family in and that's an urgent safety plan that needs to be fixed before anybody moves on with that person's plan of care.
And there are cases in which it's considered an elopement even if the person is cognitively capable and able to check themselves out of the building. If you don't know that they have left the building, if they have failed to notify anyone and they are simply gone, we do consider that an elopement.
what about items that we can notify in the morning, not at 3 a.m.?
A bruise of unknown origin that the resident's not worried about.
Yeah, so sometimes those skin tears and bruises, they do have to be reported, right? But
maybe you could wait until a slightly more decent hour.
yes.
Is that 5 a.m. or 6?
Yeah.
I think sometimes nurses are just going through checklists and they're calling in lab results and whatnot. They just get it off their desk and turf it onto yours, and they're not considering the time of night. So it's okay to let them know.
What about death notifications? Do you guys have any processes around those in your facilities about when to notify for when somebody has passed?
Obviously, if it's an unexpected death, that somebody that we weren't knowledgeable that was coming, if they are a full code and we walk in and they have passed away, CPR wasn't initiated, and then also if it's a resident that admits to the facility and they pass away within 24 hours or pretty immediate after admitting, we're going to want to notify the provider on that as well.
Any questions from the group or other? Oh, we do. Everyone is always in the back.
But I'm just curious, what advice would you give for a provider when they have a patient who's, shall we say, dabbling in illegal activity there in the nursing home, diverting the narcotics that you're prescribing to other residents for intimate relations in exchange, and you report it to the administrator, the DON, the nurses, and nothing gets done. And now they're calling you to refill their oxycodone, and it's like, why? So what advice do you have? Because you want to keep a nice relationship with that building. You want to make sure that you're not getting the building in trouble, but at the same time, you also feel on the hook for taking care of the patient and doing the right thing.
Is the medical director involved in this in any way?
The medical director is aware, but nothing seems to be getting done.
Oh, boy.
Yes. And I promise you, I'm not the only one in this building, in this room that has that problem.
I've heard it before.
Yeah.
Boy, you got to escalate it somewhere, right? So I guess I would start by going to a QAPI meeting or setting up a meeting and, saying this is not acceptable if this is occurring, and just surely you could get to some kind of logical, meeting of the minds about how you can address this. Now, if you can't get to that, if you really feel like someone's life is in danger here, you're a mandatory reporter. And there's ways to do that anonymously. Obviously, in this situation, there's not a lot of anonymity here, probably. But I guess my bottom line is you have to do what's right for the patient first. So that's where I would go if all other avenues, and I mean all other avenues, failed.
Yeah, and every facility has an upper management structure that outranks the nursing home administrator. If they are not performing to professional standard, you can escalate it up the chain. If you don't know who to call me.
I was going to say that, but I didn't want to volunteer.
Definitely done that. I send Jenny emails.
and of course my vested interest is number one, patient safety and patient care, and number two, my member care. And so I will preserve anonymity as best I can, and my goal is for that person to succeed in their role as administrator. And if they are not performing according to standard, then I'm trying to hold them accountable. We also do have the avenue of the Nursing Home Administrator Board, where you can report licenses, just like you can report a physician's license or a nurse's license, and they can put someone before a hearing for discipline and put their license under advisement. So I'd prefer it come through me first, simply because there might be more to the story, but absolutely that's within your repertoire.
That was a tough question. I'm glad I'm not on the panel.
Anyone else? Does anyone else have a question or?
An easy question?
Softball.
No. All right. Well, thank you so much. I think these are common things that we all kind of encounter on our day-to-day work, and it's really nice to be able to kind of brainstorm and work together and share best practices with one another. So we appreciate you guys participating today.
All right, thank you. Got a few minutes. We're going to reset up the stage. While we're getting our stage fixed back up, I have a phone. Did anybody happen to lose a phone? It's got a picture of a coastline on here. I don't want to put it in the raffle at the end of the day. But just know, if anybody lost a phone, we do have it up here on the front table. Okay,